Well, I want to thank the American Journal of Transplantation for highlighting the work of the University of Manitoba group as it launches its acute T-cell mediated rejection series, starting with that on kidney transplant recipients. I have some conflicts of interest, but nothing that directly impacts this talk. So despite modern era maintenance immunosuppression with tacrolimus and mycophenolic acid, we still report clinical TCMR events in the first year as between 5 and 15% on for-cause biopsies. And in terms of subclinical TCMR, it's present in 20 to 30% of surveillance biopsies in the first year. T-cell mediated rejection therapy, as outlined in the KDIGO guidelines, which have come out well over a decade ago, suggests that a biopsy is required before treating TCMR unless the biopsy is delayed. It suggests treating subclinical and borderline acute rejection, and it recommends corticosteroids for the initial treatment of TCMR. Now, if we look at clinical practice patterns, and this was a Canadian survey done in 2018, we see that for borderline grade 1A and grade 1B that are detected on a for-cause biopsy, in other words, clinical TCMR, the majority of centers are treating their patients with pulse methylprednisolone or pulse methylprednisolone and an augmentation in maintenance immunosuppression. We see that lymphocyte depleting agents or lymphocyte depleting agents in combination with increasing maintenance immunosuppressants only occurred in Banff 1B and only in 2 to 7% of centers. In terms of subclinical TCMR, first-line therapy appeared to be, again, either increasing exposure of maintenance immunosuppression in the case of borderline without steroids, or steroids and increasing maintenance immunosuppression in 55%. Whereas in subclinical grade 1A and 1B, 91% were using both the combination of IV methylprednisolone or oral prednisolone and an increase in maintenance immunosuppression. To monitor for TCMR resolution, 70% of individuals were following the renal function, and they felt that was sufficient if it was stable or improving. Only 30% used a follow-up biopsy regardless of the renal function, depending upon the initial Banff TCMR grade. In the US, we see a slightly different clinical practice pattern. In clinical TCMR, at the borderline Banff 1A, again, it's largely increasing baseline immunosuppression and either IV or PO steroids. But when we get to 1B, and especially at 2, we see that thymoglobulin or T-cell depleting agents are being used in 60% of 1B and almost 100% of 2A and greater. In subclinical TCMR, we see that, again, it's increasing baseline immunosuppression with either oral or IV steroids, and that, again, thymoglobulin still is being used in 30% of subclinical Banff 1B. TCMR resolution in the US was reported to be following renal function in 94% of cases, and up to 40% were having a follow-up biopsy. So the next questions for us, and what really spurred the research that we've reported in the March issue of AJT, was we wanted to know, in the context of TAC and MPA-based therapy, how often does TCMR persist on a biopsy after treatment? Does this differ by the initial Banff grade of TCMR? And does this differ if initially diagnosed on a for-cause or surveillance biopsy? To address these questions, Dr. Julie Ho from our group conducted a systematic review and meta-analysis, and she'll be presenting the results of this paper subsequently. The other question we had was, again, in the context of what is modern immunosuppression, what is the impact of a first TCMR event? And does this differ by the initial Banff grade? And what is the impact of a second TCMR event? And does this differ if it's defined as being persistent, i.e. recurring within the first 6 months, or subsequent if it's occurring after 6 months after the initial event? To address this question, Chris Wiebe led a project in our group that looked at the negative impact of T-cell mediated rejection on renal allograft survival under TAC and MPA-based therapy. So where do we go from here? After you've heard the 2 papers being presented that are in the March issue, there's going to be a subsequent live panel discussion with the AJT Journal Club. And this will be led on the 29th of March at 8 p.m. Central, or the 11th of April, 10 a.m. Central. And you can decide which one you want to tune into. And the details can be found on the AJT website. So with that, I'm going to turn it over to Dr. Julie Ho.
Thank you for the kind introduction, Peter, and also to AJT for allowing us the opportunity to present our work. Today, we're going to discuss the effectiveness of T-cell mediated rejection therapy, a systematic review and meta-analysis. I have no relevant conflicts of interest to disclose. Early TCMR events can have multiple potential outcomes. We know that early TCMR is an independent predictor for the development of de novo donor-specific antibody and chronic active antibody-mediated rejection. Sequential biopsy studies have also shown that early TCMR can evolve into chronic active TCMR or resolution of inflammation. Therefore, we sought to ask the following questions. How often does TCMR persist on biopsy after treatment? Does this differ by the initial Banff grade or severity of the index rejection? And does it differ if it is a for cause or surveillance biopsy or a clinical versus subclinical rejection event? To do so, we conducted a systematic review according to the methodological expectations of Cochrane reviews and reported them by the PRISMA guidelines. We developed a peer review search strategy using the PRESS checklist, and this was independently reviewed by an academic librarian. We pre-registered our methodology and outcomes on the Prospero website with our registration number included here. And all studies were graded using an NIH study quality assessment tool. 2 independent reviewers are used for screening, scoring, and data extraction, with a 3rd reviewer used as needed to resolve conflicts. The meta-analysis was conducted using an inverse variance random effects model and reporting of binomial proportions, and statistical heterogeneity of the pool proportions was evaluated with the I-squared statistics. Our search focused on kidney and kidney pancreas transplant patients on modern maintenance immunosuppression with TAC and MPA, with the search going from January 2015 to January 2021 in English language publications. Our primary outcomes were persistent and recurrent TCMR events with follow-up biopsy after the indexed TCMR treatment. We defined recurrent TCMR as requiring at least 3 sequential biopsies with an indexed TCMR event, normal histology in between, and a subsequent TCMR event. However, none of our studies identified had sufficient serial biopsies to characterize recurrent TCMR. Therefore, all the outcomes reported in this paper are for persistent TCMR only. However, in the subsequent presentation, you'll hear Dr. Chris Wiebe presenting on the clinical and prognostic significance of recurrent TCMR events in sequential biopsies in the Manitoba cohort. We retrieved 4,298 citations, of which 2,875 were screened at the title and abstract level, and 494 full text articles were screened. This resulted in 12 articles that were included, which consisted of adult and pediatric kidney transplant patients, with the study periods ranging from 2004 to 2019. These were primarily observational studies with 1 single center RCT. All were graded as moderate to good quality studies. Notably, there is significant heterogeneity in the treatment of TCMR with respect to dose, duration, and indication for steroid use, as well as indication for thymoglobulin use. There is variable time to follow-up biopsy as well. This is our primary outcome, of which was persistent Banff greater or equal to borderline TCMR after treatment of an index Banff greater than equal to borderline TCMR event. The pool proportions identified a 39% reduction in the 39% persistent TCMR on follow-up biopsy. You can note that there is significant heterogeneity with an I-squared statistic of 77% with a p-value of less than 0.01. All the subsequent studies did have statistically significant heterogeneity. We then wanted to explore whether or not the severity of the index rejection event impacted the proportion of persistent rejection after treatment. And we found that the proportions were the same when the index event was a Banff greater than equal to 1A TCMR. 39% still had Banff greater than equal to borderline on follow-up biopsy. We then wanted to explore whether or not subclinical versus clinical rejection, or whether the index biopsy was a protocol versus a clinically indicated biopsy, impacted the proportion of persistent rejection on follow-up biopsy. There was a 46% persistence of Banff greater than equal to borderline TCMR after treatment of a subclinical Banff greater than equal to borderline event. Similarly, there was a 41% proportion of persistent Banff greater than equal to borderline TCMR after treatment of a clinical event, which was Banff borderline or greater. We then wanted to explore the impact of untreated rejection. These were predominantly untreated subclinical borderline events, as the majority of clinical borderline events were treated. But we did identify that 61% of Banff greater than equal to borderline rejection was present after lack of treatment of an index Banff greater than equal to borderline rejection. We had a number of pre-specified subgroup analyses, of which I'd like to highlight two. The first is that pediatric transplant patients had a very high proportion of persistent rejection and follow-up biopsy of 54%. And when we focused on kidney transplant only studies, excluding the two studies that included kidney pancreas patients, that the proportions remain similar, with 42% of patients having a Banff greater than equal to borderline TCMR after treatment of an index event. There are a number of limitations to the study. This was a secondary analysis of primary observational studies with only one single center RCT. And most of these studies, this was not their primary outcome. There was significant study heterogeneity, as demonstrated by the I-squared statistic, with variable treatment approaches, variable follow-up biopsy durations. We defined TCMR remission histologically as the absence of BPAR in a follow-up biopsy. However, only a subset of the patients in studies had actually a follow-up biopsy within a reasonable time frame. Therefore, this biased our study inclusion to those that are protocol biopsy programs. What is truly lacking is an internationally accepted consensus definition for the remission of TCMR. So from a conceptual framework, early TCMR events can lead to the development of de novo DSA, chronic active ABMR with reduced graft survival. Alternatively, it can evolve into persistent TCMR, which can contribute to the development of de novo DSA or chronic active TCMR with reduced graft survival. However, as a transplant community, we don't have effective therapies for these chronic inflammatory pathways for chronic active ABMR or TCMR. Therefore, the question is, are we able to better define and optimize early TCMR treatment in order to achieve higher rates of TCMR remission, resulting in absence of graft inflammation with improved long-term graft survival? So in summary, we conducted a systematic review and meta-analysis in patients on modern TAC-MPA-based maintenance immunosuppression to determine how many achieved histological remission after treatment of an index TCMR event. We reviewed English language publications from 2015 to 2021, and 12 studies met our inclusion criteria, all of which were moderate quality or better. And the pooled results found that 39% of patients had a persistent greater than equal to Banff borderline TCMR on follow-up biopsy within 2 to 9 months after treatment of rejection. There was considerable heterogeneity in anti-rejection therapy, which really reflects the lack of robust randomized controlled trials to define the optimal approaches for treatment of TCMR, which is foundational for transplant care. So I'd like to finish by thanking my co-authors for their academic contributions, our librarian for providing an independent peer review of our search strategy, the authors of the included studies who kindly provided us with line-level data to ascertain outcomes, as well as funding from the Paul I. Terasaki Research Fund. Thank you very much. And I'll pass it over to Dr. Wiebe.
Well, thank you very much for the opportunity to be part of this first journal club. As you can see, the title of the paper is The Negative Impact of T-cell mediated rejection on renal allograft survival in the modern era. I have no conflicts to disclose. I'm going to start by talking about the study design. This was a retrospective cohort study of 775 renal transplant recipients. You can see the demographics are on the right-hand side, but I want to highlight that these are all patients on maintenance therapy with tacrolimus, mycophenolate, and prednisone, and that all patients had DSA ruled out at the time of transplant using single antigen bead assays. Surveillance biopsies were routine at 6 months in this cohort and were done at other time points for select patients that were part of other studies. Also, histologic evaluation was standard of care post-TCMR and ended up occurring in about 78% of patients after a TCMR event. The outcomes of interest were death censored and all-cause graft survival. As you can see in this figure, this is the timing of the biopsies, with for-cause biopsies being shown here in the top panel and surveillance biopsies in the middle panel. There were a total of 1,685 biopsies, and these were roughly split 50-50 into for-cause and surveillance. That resulted in a 23% prevalence of biopsy-proven acute rejection by 12 months post-transplant, and that rose to 32% by 5 years. Now, this figure shows the 229 patients who had a first TCMR event. 93% of these were pure TCMR and 6% were mixed rejections. And what you can see here in this figure is that, again, the majority of these were borderline, and the borderline rejections were roughly split 50-50 between surveillance and for-cause, whereas the other more severe Banff grades tended to enrich towards for-cause biopsies. I think one of the unique things about this study is we didn't just stop at the first TCMR event, we also looked and quantified subsequent events. Again, here in the first part of this histogram, you see the 229 patients with the first TCMR event, and you can see that 50% of those actually had a subsequent event on follow-up biopsies. And it wasn't just the second TCMR. After each TCMR event, greater than or equal to 50% of patients had a subsequent event at later time points, and consistent with what Dr. Ho just showed us from the literature. And I think this behooves us to ask, why is this happening and why is TCMR so persistent? Well, one potential hypothesis is that patients have a persistent risk factor. Some of you will know that we've been interested in looking at HLA molecular mismatch against the class 2 antigens in our center for a number of years. And the figure here in the bottom left just shows the single molecule mismatch scores using an eplet mismatch to quantify the molecular mismatch. We use these scores to help us develop a alloimmune risk categorization that could potentially be used as a prognostic biomarker. What we showed in this 2019 paper was that these alloimmune risk categories correlated well with de novo DSA development, with ABMR, and with TCMR. Now, this study, getting back to the data from the current study, we use these alloimmune risk categories to correlate with TCMR frequency. And what you can see in this figure is that patients who had at least one TCMR episode in the middle of this figure were already enriched for intermediate and high risk patients. And if you had greater than or equal to 2 TCMR episodes, the high risk subgroup predominated, and this was significant in a chi-squared analysis. Similarly, we use the alloimmune risk categories to correlate with the Banff severity of TCMR. And here we took the most severe rejection for any given patient. And what you can see again is that patients who had a borderline or a Banff 1A rejection were enriched with intermediate and high risk patients, whereas those who had a greater than Banff 1A rejection tended to enrich towards the high risk alloimmune category. Now, I want to take a few minutes to just talk about how do we study the impact of both TCMR and ABMR in the same cohort as it relates to allograft survival. So this is actually just a theoretical figure that I've put here. This is not data from the study, but I wanted to show this. You can imagine here that possibly this green line would be patients with no TCMR or no rejection at all. The blue line might be patients with TCMR, and the red line could be patients with ABMR. And we've seen many figures like this in the literature, where this is a Kaplan-Meier curve with time of 0 being the date of transplant. But as many of you will know, and many people have pointed out in the literature, there's a flaw in this analysis because we don't actually know what these assignments are at day 0. And some have called this immortal time bias because by definition, you have to survive to 3 years in order to have an event at 3 years. So to get around this limitation, some have said, well, why don't we change time 0 and make time 0 the time of the biopsy? So for example, if we biopsied everyone at 1 year post-transplant, time 0 could become that 1 year time point. However, there's a few limitations to this approach as well. For one, TCMR and ABMR tend to occur at very different time points. TCMR tends to be an early event and ABMR a late event. And that's particularly true in cohorts like this, where DSA was ruled out at the time of transplant, and that so all the ABMR events are going to be de novo DSA. Another limitation of this type of analysis is that events prior to the 1 year time point are ignored, and events after the 1 year time point are also ignored and not considered when we're looking at the hazard ratios. So to get around this limitation, a third type of analysis has been published multiple times, and this is called a landmark study, where all of the events up to the landmark are considered when you categorize the patients at the time of the landmark. As many of you know, the landmark is arbitrarily chosen by the investigator. I'm just showing you a 3-year example here. And there are a few limitations to this type of analysis as well. First of all, patients who die or fail before the landmark are then excluded from the study, and reducing the power. Events that occur after the landmark are still ignored. And thirdly, as I pointed out earlier, the perfect landmark is likely different for TCMR and ABMR. One could imagine that the perfect landmark for TCMR might be 1 year or 18 months post-transplant, whereas for ABMR, you probably want a landmark at 4 or 5 years post-transplant in order to have enough events for the analysis. So to get around all of these limitations, we use what was called a extended proportional hazards model that includes both the baseline covariates and the time-dependent covariates on the date that they occurred. So the way to think about this in your mind and visualize it is it's kind of like doing a continuous landmark study each day post-transplant. So for example, if an event occurs on that date, then that event that contributes to the hazard ratio based on the date that it occurred. So getting back to the data from this study, how does this look and how does it work? Well, these are the baseline demographic models. We have death-censored graft loss on the left and all-cause graft loss on the right. And what you can see in these multivariate models is, for example, for death-censored graft loss, is that recipient age was a multivariate predictor, where for each increase per decade, the hazard ratio shows that the risk of death-censored graft loss went down up to age 50, at which point it became a flat line. And for all-cause graft loss, as you would expect, as recipients got older, the risk of all-cause graft loss continued to go up, and deceased donor status was also associated with all-cause graft loss. Now, if you look carefully at these risk factors, you'll notice that these are all things that can be measured on day 0 of the transplant. So to these baseline models, we then start adding our time-dependent events when they occur. So the first thing that occurs in time is delayed graft function. And as you can see here in model 1, after adjusting for the baseline covariates, delayed graft function was a significant multivariate predictor of both death-censored graft loss and all-cause graft loss. Now to this model, we created a second model where the rejection events were added. And you can see here that even after adjusting for the baseline predictors and for DGF and for ABMR, that a first TCMR event was a strong predictor of both death-censored graft loss and all-cause graft loss. Now within this model too, we did a few sensitivity analyses. The first is we looked at the biopsy type. Was it a for-cause or surveillance biopsy? And what you can see is that the for-cause biopsies were associated with a hazard ratio of 4.06. That was highly significant for death-censored graft loss. Whereas the surveillance biopsies had a hazard ratio of 1.94. This wasn't quite statistically significant at 0.086 for a p-value. And these hazard ratios in general tended to be lower in the all-cause graft loss, as you'd expect. In a second sensitivity analysis, we looked at the Banff grade of this first TCMR biopsy. And what we saw is even if the Banff grade was a Banff borderline rejection, that those are associated with a hazard ratio of 2.90 that was highly statistically significant for death-censored graft loss. And again, these hazard ratios were lower in the all-cause graft loss. Lastly, we did a model 3 where we added the second TCMR event to the model. And you can see here that even after adjusting for the baseline predictors, for DGF, for a first TCMR, and for antibody-mediated rejection, a second TCMR event was strongly associated with both death-censored graft loss with a hazard ratio of almost 3 and all-cause graft loss with a hazard ratio of 2.3. To this model, we then did one final sensitivity analysis where we looked at the timing of this second TCMR. So for this, a second TCMR that was persistent meant that it was back-to-back TCMRs within a 6-month period, whereas if it was subsequent, we define that as a TCMR that was more than 6 months from the first event, or there was a normal intervening biopsy between the two TCMR events. But you can see here that it didn't really matter. Both persistent and subsequent events were associated with a strong hazard ratio of death-censored and all-cause graft loss. So to summarize, we found that in a cohort that were treated with modern immunosuppression, that a first TCMR event, including Banff Borderline, correlates with death-censored graft loss even after adjustment for ABMR and our baseline predictors. A second TCMR event carried an even greater risk of death-censored graft loss and correlated with all-cause graft loss. These findings highlight the need for clinical trials with novel therapeutics that may help us reduce graft loss via, number one, the prevention of a first TCMR event. I think this is potentially low-hanging fruit, since we know from cohorts on modern immunosuppression that 20 to 30% of patients will have a greater than or equal to Banff Borderline event in the first year to 18 months if surveillance biopsies are done. And as some have said, the limitation here is that if 30% of patients are having an event, that means 70% aren't having the event, and we don't necessarily want to augment their immunosuppression. However, this is an opportunity where we could use HLA molecular mismatch to target the more intense immunosuppression for those who are likely to benefit. And finally, graft survival may also be reduced by effectively treating the first TCMR event with a novel agent to prevent a second event. And that second event could be a TCMR, it could be a de novo DSA, plus or minus an ABMR. So I want to acknowledge the many contributors to this study, as well as our funding sources, and thank the Paul Terasaki Research Fund for their generous contribution.